Thank you.
So our last speaker is Dr. Nilesh Patil. He would be talking about major hepatic resection for locally advanced hilar cholangiocarcinoma, experience from a tertiary care center.
I'm Dr. Nilesh Patil from IASGCON Hospital. First, I want to say thanks to the organizing committee for giving me the opportunity to share our experience. As we know, to operate the hilar cholangiocarcinoma, especially the locally advanced hilar cholangiocarcinoma, is technically challenging because it's complex, close and variable relationship between the biliary and the vascular structures. The resectability rate has been reported in the literature extends from the 30 to 80%, and the R1 resection rate has been reported because of the complexity of the surgery up to tune of 20 to 30%. And the mortality rate of 0 to 9% and 5-year overall survival up to 30 to 40%. Also, some centers have reported the morbidity up to 60%. So basically, it is a retrospective analysis over the 11 years. Total 74 patients we planned for resection with the suspected malignant hilar block. Out of that, 18 patients were abandoned. Of the 8 had a metastasis. In this, 6 patients had peritoneal liver mets, and 4 patients had after staging laparoscopy, we routinely do the intra-aortic frozen section biopsy, and it came to be positive. 3 patients found to be cirrhotic on staging laparoscopy, 3 were unfit for surgery, 2 had a locally advanced disease because there was a involvement of hepatic artery and it was a non-reconstructible, and 2 had inadequate remnant. 7 found to be benign and 15 found to be malignant. In that, type 1 and 2 hilar cholangiocarcinoma were 10, CAGB neck was 3, and 2 were SCC with bile duct thrombosis. So finally assessed these 34 patients which underwent surgical resection for type 3-4 hilar cholangiocarcinoma. This is basically a locally advanced hilar cholangiocarcinoma which extends both the bile ducts. Sometimes they extend bilateral secondary biliary radicals and also sometimes involve the vascular structures, the portal vein or the hepatic artery. The primary outcomes assessed included the perioperative results, morbidity, mortality, and the long-term survival. So the median age of the study group was 15.5 years, and almost 35% of the patients had aged more than 60 years. There was a male dominance in the study group with 70% of the patients. The most common symptom, as we know, the 77% of the patients had a jaundice. 32% of the patients presented with the cholangitis, followed by weight loss and the pain abdomen. The type of the hilar block on the MRCP, there was a 17 patients had a type 3A hilar block. That was a Bismuth type 3A, and type 3B was in 11 patients, and 6 patients had a type 4 block. So as a routine, in jaundice patients, in 30 patients, we did PTBD of the future liver remnant, and 4 patients underwent afferent surgery. In that 4 patients, they had the bilirubin level was less than 10 milligram, and the duration of the jaundice was short, it was less than 2 weeks. And they don't had a cholangitis, and the remnant was more than 40%, so underwent afferent resections. 20 patients required portal vein embolization for the augmentation of the future liver remnant. 6 patients we didn't do portal vein embolization because they already had a atrophy hypertrophy complex because of the portal vein involvement. The median CA99 level was a 14.5. The pre-drainage total bilirubin was 12.9. The pre-surgery total bilirubin was 2.1, and the serum albumin, median serum albumin level was 3.2 gram per deciliter. We do routinely the liver resection with CUSA. The type of the liver resection we performed with 14 patients underwent right hepatectomy, 10 had an extended right hepatectomy, 9 patients required left-sided resection, and 1 patient underwent extended left hepatectomy. Total 10 patients required 12 patients required vascular resection. In that 10 were portal vein resection. In that 7 we performed segmental resection with end-to-end anastomosis, and 3 patients required sleeve resection. And the 2 patients, especially both were left-sided resection, required right hepatic artery resection. It was a right artery resection with end-to-end anastomosis. And the duration of the surgery was long. At the median was 480 minutes, and the intraoperative blood loss was median was 860 ml. Total R0 resection was 76%, and R1 resection was in 24%. There was a associated liver involvement in the 6 patients, and 15 patients had a T2B disease. And we noted the size of the tumor more than 3 centimeter, almost more than 50% of the patients. The lymph node involvement was positive in the 59% of the patients. The grade 2, grade 3 tumor we noted in the 47% of the patients. There was associated the lymphovascular invasion in 35% of the patients and perineural invasion in the 58% of the patients. And importantly, the major vascular invasion was present in the 24% of the patients. Regarding the post-op morbidity, our post-op morbidity rate is which was assessed by the Clevin-Dindo classification. The major morbidity was only 29.4%. The bile leak occurred only in 2 patients, and both were managed conservatively with required PCD for the bilioma drainage. And total 12 patients had a postoperative liver failure in the form of prolonged ascites and encephalopathy. In that, grade C was 3 patients. Out of that, 2 patients had a mortality. One was because of bacterial sepsis, another was because of the fungal sepsis. Regarding the survival, we analyzed by the Kaplan-Meier analysis, and overall 1-year survival was 80.3%, 3-year survival was 64.7%, with median follow-up of around 22 months. Recurrence-free survival was 77.9%, and 3-year survival was 40%. And total 6 patients had a local regional recurrence, 3 patients had a combined recurrence, and 2 patients had a distant recurrence. We also compared the survival between R0 versus R1 resection. In that, patients with R1 resection had total 8 patients had R1 resection. Out of that, 6 patients received radiation plus chemotherapy, and also patients with lymphovascular invasion and major vascular invasion and poorly differentiated tumors also received gemcitabine plus cisplatin chemotherapy, total 6 cycles. And there was no statistical difference, but there was a slightly lower survival as compared to the R0 resection. This was one of the pictorial of the precise and surgical technique. We basically delineated all the lymph nodes from the HDL. The first picture is showing the inflow of the future liver element has been looped. Basically, it is a left-sided resection, and the patients required a segmental portal resection with end-to-end reconstruction. This was another pictorial representation of the hepatic arterial resection. Basically, it requires extended left resection with the right-sided hepatic artery involvement and underwent segmental resection. The same patient also had a portal involvement, but it was only sleeve resection. Regarding arterial resection, long-term, both the patients didn't have issues, and on portal resection, only one patient had after 2 years. Basically, it was a hebicore positive patient with underlying CLD. Patient had a PVT and they developed portal vein narrowing. We required portal vein stenting. And this was an extended left-sided resection, and we can see the nicely transected cut surface with RHV seen on the cut surface. So basically, the preoperative optimization and skill and precise meticulous surgical technique, we can give the almost 75% of the R0 resection, and this is the best opportunity to achieve marginal negative resection and improve the perioperative results and the survival in type 3 and type 4 hilar cholangiocarcinoma. Thank you.
Thank you, Dr. Nilesh, for your presentation. I have just 2 simple questions. How did you measure blood loss?
Sir, basically from the MOPS, and also do you
systematically do that?
Yeah, we do systematically.
Because 890
basically,
cc?
we do in transplant also. The irrigation saline, we do it in the minus from the total volume.
And can you comment on the R1 patients? Was the R1 was in the duct or in the liver parenchyma or in the vessel?
It was duct.
May I finish the question, please? And what is the correlation between R1, perineural infiltration, and lymph node positivity? How many of the R1s happened in patients who had neither perineural or perivascular vascular infiltration and who had lymph node negativity? Do you understand my question?
Yes, I understand my question. Total 8 patients had an R1 resection. All had it was a bile duct margin positivity. And out of 8, sir, 3 patients had a lymph node positive. Came to.
Your R0 resection rate was about a quarter of the patients, right?
Sir, R0 resection.
R0 was in
76%.
R0 was 76%. Okay. And still you have a survival which is similar, at least in the medium term. How do you explain that?
Sir, because we have newer adjuvant chemotherapy drugs, and even with R1 resection and with patient with lymph node positivity, we have used the gemcitabine with cisplatin combination, and that may be the cause that giving equivalent survival between R0 versus R1 resection.
The regimen used was different?
Gemcitabine plus cisplatin. And in R1, 6 patients also received radiotherapy for positive margin.
Sudeep Shah, congratulations on your very transparently presented data. I have two questions. The first is the title of your scientific presentation. You've called it locally advanced hilar cholangiocarcinoma. We know in pancreatic cancer there's locally advanced pancreatic cancer, which is different from borderline resectable pancreatic cancer. What is locally advanced hilar cholangiocarcinoma, and are all your cases locally advanced hilar cholangio? Would be my first question.
As such, there is no consensus on that, what is a locally advanced hilar cholangiocarcinoma. But whatever is the available literature, especially the review article published by Professor Mohammad Rela, and that included which involves bilateral, both right and left ducts, or extend to bilaterally biliary radicals, second order biliary radicals, or involvement of portal vein or artery.
So anything
basically it involves the bismuth type 3, type 4, and associated with vascular involvement on pre-op imaging.
So that would be what you would call a locally advanced.
Yes, sir.
Right. The second question is, what is the message in this paper which is not already known to all the members in this audience?
This is not the uniqueness about, but basically you are strengthening the evidence, and very few centers, governments, especially in the government sector in India, are doing these complicated dissections. And with the skillful and precise, especially on the background experience of the transplant, we can even salvage these patients.
Introduce yours.
Myself, Dr. Ashish. I am working as an assistant professor in KGMC, sir. It was a nice presentation. A small doubt in your data analysis in your results, sir. You had 77% patient who had jaundice, but you had 30 patients out of 34 which had pre-op PDPT, which close to 90%. So what were the other indication apart from jaundice which required PDPT?
Sir, basically it was, we routinely do if the jaundice is more than 5 milligram. And also the main indication was the cholangitis. And in 4 patients, we don't do that, I already told, and we routinely do PDPT.
Does your cases include carcinoma gallbladder in the neck, as you said?
No, I excluded already.
You excluded.
3 patients were CAGB neck, that has been excluded.
If there are no further questions, we'll stop. Thank you, Nilesh.
Thank you.